Welcome, everybody. I'm the president of GuidedSMILE, and I've been running this company, this company for about a little over 2 years now. I was embedded in a laboratory for about 20 years, and then we moved out, and our only customer now is dental laboratories. So we work with a network of labs all around the country. We have a lot of fun doing it. We have a big team, about 35 people. And all we do all day and night is make surgical guides for doctors by way of dental laboratories. And I suggested this topic because it has become kind of near and dear to my heart as we focus a lot on full arch cases. That is our primary product. And we make all types of guides, every kind of guide that you'd ever need for placing an implant, period. But our primary product, our flagship, is Chrome GuidedSMILE. And what we found over the years is that a lot of these cases, some of them that we do, and obviously some that don't go through us, need what's called revision. And I'm going to talk about that today, almost exclusively about these revision cases. And I'll define that in just a minute. But here's the agenda. I discuss and define revision. I'm going to spend some time on these challenging cases that we worked through and go through how we overcame the challenges of these patients with existing full arch implants and prosthetics. Review fixed and removable cases. I'm going to talk a little bit about the records, and I can share checklists with them, anybody who's interested, and then just a little bit of statistics. And what is fascinating is the quantity of full arch cases in America. And I have a pretty good source that in last year, the calendar year, there were about 100,000 full arch cases completed. And that's fixed, removable. That is specialties, private practice. TSP is total service provider, like super GPs. A lot of it's corporate, as you can see, about 60%. And then, of course, a lot of them come from dental tourism, too. So that raises that number. We see a lot of cases coming from overseas. And so that number is going to be off a little bit because that number is based on multi-unit abutment purchases in America. And that number is going to be higher because there are systems out there that don't use multi-unit abutments, right? So it just keeps ticking up a little bit more. And what percentage of these cases over the years need retreated? That's the main subject of tonight. I mean, just how many are we going to be expecting over the years? And I have a graph coming up where I make some predictions based on historical numbers. And what is the life expectancy of these cases? Traditional hybrids with titanium bars, 12 to 15 years. That's what we used to be told. That seems to be about right, unless somebody's really abusing it. Zirconia, I don't think we really know yet. We're only about really 10 years into solid full arch zirconia. Yes, before that, but really transitioning over. And I think they're going to last longer. Certainly the materials will, but what happens to the case, to the implants, to the bone? Still a little bit of science left to be studied on that. And then these full arch centers are popping up all over the country, right? So many, there are so many of these full arch, same day, next day, that we know the numbers are just going to keep going up. And I put this image on the bottom. This is an email and an image that I received this morning. I get these just about every day. Hey, I have this case. What do I do with it? And we want to help because we know that now and in our recent past, which is 30 years of doing full arch cases, look how these numbers are going up. And again, some of this is estimated based on where we are now, 100,000 a year, with a 7, 8, maybe 9% growth now. But look where these numbers go in the next 20 or 30 years. And who's going to be restoring these? Maybe you, maybe another generation in 20 years. But there has to be a system in place for accepting these patients because they're not straightforward at all. And And as you'll see as we go through these cases, there's lots and lots of challenges with restoring these cases. So what's a revision case? It's a patient, it's a person who has existing implants. So that's a starting point for everyone. They have implants, they have existing fixed or removable prosthetics, and there is either an event or wear and tear, poor planning on the original version. Something is going on where this patient now needs more implants, more componentry, maybe just a new prosthesis, retread, or a whole new prosthesis for some reason. But they usually need more implants and they usually need more teeth. That's what you'll see here, especially tonight in this program. And this program is about guided surgery protocols, right? Not freehanding. That's a whole different avenue. This is about how to set a case up for planning a case, and also digital and analog workflows. You know, if you're a fully digital office, you plug this right into it. If you're an analog office, or if this is a redo of some records that you already have, maybe it's more of an analog process. That's okay. But putting the implants in and planning these cases is a digital workflow. That's what we're going to talk about today. And I want to spend a little bit here. This is really special thanks to Dr. Castedo and his team. All these cases that I'm going to show tonight are with his team. And we have completed many, many, many cases. About 90 cases, and about 60 of those are revisions just in the past 8 months, just because of the zip code that he's in. And he is dealing with, some catastrophes and just some wear and tear and retreatment. We'll go through a bunch of them. And thanks a lot for his team, too. His team is awesome. Savannah, Christina, David, Sandy, Teresa, Lillian, Amanda. The last two are my team here at GuidedSMILE. And Sandy is the Nobel rep. These are all NobelSMILE voucher cases. That's our big partnership we have with Nobel Bowel Care. And then Savannah and Christina are his assistants. David, Teresa run the show. So thank you very much to them. They just do some great documentation that made it possible for us to go through these cases and share what we've done. So I'm gonna just quickly go through a whole bunch of pictures to show you what this is about. All right, so this is a fixed revision case, bone loss, prosthetic, obviously an older prosthesis, traditional methods, but it's time, and it's going to be time for all these to have a revision. This would be placement in poor areas and bone loss for a health problem, but cases like this are just almost impossible to restore. And I say that after 24 years of doing these. Yes, we could sit here on this screen and talk for an hour about what to do with this case. I get it. Okay, there are many avenues, but the cases that I'm going to show tonight are the ones that we've worked up together, Dr. Castedo and my team, and we've worked them up and we've gone a certain avenue, and I'm going to go over how we treat them, even though there are 10, 20 different avenues to take to restore these cases. So these type of cases, implants too small, bone loss, just issues, prosthetic space. These are the kind of cases that walk in his zip code every day. And there are really no other doctors in town to treat them. No offense to any other doctors in town. It's just in this particular town, there aren't many, if any, full arch doctors who can take on these types of cases. So I don't need to go, I don't really need to speak too much about these. You see these and you say, yeah, okay, yeah, it's time. It's time to do something for these cases. Too small of implants, the patient wants a lower fixed prosthesis, the upper, there's just not enough implant there to support a fixed prosthesis, and patients made a decision, and we're going to go that route. This is upper denture not fitting well, lower natural teeth. And what I'm going to do is I'm going to show you a photo and then the pre and the post. And I'll just keep going through these, and then we'll get into some real, the meat of it and the details here in just a minute. So, and I see some chats. Please do post questions, anything. open book. Whatever you'd like to ask, I will try to answer at the end. All right. So I have some notes on the right, but I wanted to shrink them because I accidentally kept track of all the patient names in here for myself, just so I would know as I'm putting these together. It's If you've put together a PowerPoint, you'll know that it's about 40 hours per hour. So it's tough to keep track of all these slides. So, we're going to go through this case. This was a nice one, real nice. And it was time for him. He was in a removable and then he went to fixed, natural teeth fixed. You see this? Revision, lower denture, upper fixed. But it's the revision part. These patients walked in with implants. And maybe it's a freehand situation for a lot of doctors, but as you go through these slides and you see the types of cases and you see the symmetry that Dr. Castedo introduced into these implants, the left and right, the balance, you'll see a lot of pterygoids. You'll see a lot of, maybe you'd say it's over-engineering, but he wanted molars. He wanted the patient to have good, solid function. So we added a lot of implants. And you can imagine the longevity of a case like this, right? Because of the number of implants, the balance of the implants, the structure, the engineering that went into it. So I hope I'm not boring you, but I just want to take you through all these cases, and he documents them marvelously. All right. So again, I'm just going to go through a few more, and you can see the amount of work that goes into these cases. And again, the symmetry, the structure, the engineering. Okay. So boom, there it is. What he and I and our team have tried to do is move away from this. Patient has implants. You take an implant or multi-unit abutment level impression and you make a model, then you scan it, then you bring it into the CT and the plan and the intraoral scans or whatever it is, and you try to align all these things and then try to make an accurate guide. It is tedious, very tedious, and it's a soft tissue impression, so it's going to be tough to make a surgical guide fit this intimately, perfectly, to line up implants between other implants, to put in pterygoids from a surgical guide. All right, so we need precision. So we're going to move away from that type of case that we did for years, even up until last year. And we're going to go more of a digital precise route. So this first wave of cases that we're going to talk about are transitioning from a removable prosthesis or prosthetics to fixed. And what do we do? What do we analyze? What do we do? What are the records? And then how do we go about it in surgery? So one of the very first things that we have to do when you're going from this to this is that we have to analyze a few things. First, we have to make sure we have enough prosthetic space, right? If you know the elementary things about full arch, you have to make sure that you have prosthetic space for fixed, right? So it's a pretty easy way to analyze it. It's a ridge to ridge. I mean, you can do vestibule to vestibule for bite and all that, but ridge to ridge, bone to bone is a pretty simple thing to do, especially if a patient's already in a removable prosthesis. Do a dual scan, send it over, or you take a measurement. You can see, I'm going to talk about a few different things here, but one is how much bone reduction, how much display. You can see the necks of the teeth, and then the necks of the teeth in that red line, and then above it. All that is going to be displayed when you go to fixed, because that's where the tissue is, underneath it, right? I'm going to show you in a cross-section how we see that. And then, do we have enough vertical space, and what are we going to do about it? Right? Are we going to open the bite, or are we going to reduce bone, or a combination? These cases, when you go fixed over fixed, you need at least 26 millimeters from implant to implant, because you subtract for tissue and then you add for prosthetics, right? So today, yes, you can get away with doing a 10 millimeter prosthesis. We don't want to, but we will. So anything 10 or higher is going to be acceptable. Now, you got to keep in mind, though, that 10 millimeters of prosthesis is going to have a gummy smile, is going to have a display of a transition line, right? So that's not going to work. And you can see on that right image, that is from gum to gum in a cross-section of the dentures. An easy way to measure it. So there's your space that the patient currently has. The other images show the smile. And then so that we make a determination, right? Are we going to have to reduce bone? Yes, we're going to have to reduce bone if you're going to go into fixed. That's a decision. And then the other is a cross section from the profile to check out lip support, because many patients need a flange. And if you don't have a flange, then you have a ledge or you stop providing lip support. Very important. All right, next patient. This is the smile is not quite as exposed, and you really want to be careful that the patient is giving you the full smile. And a little trick to that is, yes, you make them laugh. Yes, you tell them to smile as hard as they can, and then you have them close their eyes and do the biggest smile they can with their eyes closed. The muscles change. There's nice papers written on this to prove that a patient's lip will come up when their eyes are closed. All right, they may show you another 1, 2, 3, 4 millimeters. You never know, but you don't want any surprises. So here we are with another analysis, maybe a little bit of bone reduction. The inter-arch space, tissue to tissue, is only 17.3. So that has to be addressed. Either bone reduction or opening the bite. In this case, is going to be some bone reduction. Look at the flange. This is major decision time here. Bone is going to be elevated. You're going to lose a little bit of labial, not much. Patient has a lot of bone, but they don't have labial bone. And you're going to end up with a ledge. And you have to talk through it, because you can't make a flap, a ridge with a fixed prosthesis. Can't do it. So this is a discussion. Not all patients should go into fixed. Here's another, right? Same thing, 13 millimeters of space, and going to have to do augmentation, probably open the bite. You want to verify speech. You want to go through the whole protocols when you're going from removable to fixed. Flange is fine, no problem there, acceptable. And so those are the evaluations for denture wearing patients, especially the maxilla, right? Go through those processes either with us or on your own and help determine it. So let's go through a case where a patient is in an patient's in removables, upper and lower, and the patient wants fixed restorations. All right. So this is Beatrice. We're going to tell her story. So when this patient says yes, we're going to talk about the records. And the reason that we want to do guided surgery, doctor wants to do guided surgery, is multifold. One of them is we need to put these implants in specific strategic places where the bone is left, where the bone is remaining, usually very close to other implants, between implants. The real estate is quite limited, right? So we want to have a surgical guide that fits and puts those implants exactly where they're planned, as opposed to just exposing and putting implants in, right? Or randomly doing bone reduction, because we plan the whole thing from teeth down, right? So real estate is limited. And then you think when you're actually in the surgery, we have fixation pins, we have old implants, we have new implants, and we have to dial it in. Very, very precise. That's why guided surgery is such a wonderful thing. Now, what you're going to find is that the records are going to dictate the precision of the surgery. These are traditional dual scans. And what that means in traditional dual scans is, like we've always learned, is that the denture becomes the pin guide. All right. Now, this patient was all acrylic with some locator parts. All right. It still makes a little bit of scatter, especially obviously around those sites. But historically, we would have relied upon this to be the pin guide. And we would say, well, the pallet's going to hold it in place mostly, the ridge a little bit. Maybe you'll get a little bit of contact on those locators. But when you need this kind of precision, that's not good enough. And so this is one of our early cases, and we do debriefs after these surgeries. And we say, this situation where the pin guide is going to rotate. It is going to move, and everything is going to be a little bit off. And we can't have that. All right, so this is an early one. And when you generally, in these cases, you lay a labial flap first, you install the guide, you pin it, you hold it firmly in place, and you pin it. And as you can see from that pin guide, the way it was designed in the intaglio, that's going to be a bit of a struggle to make this thing fit perfectly, right? Yes, it goes down, but it's not a perfect intimate fit. Less than what we want. You can see the fixation base, which is our bone reduction guide. That metal is a fixation base, pretty close to what the plan is, right? But there might be a little bit more gap on the patient's right, a little bit more. So it's not in there perfectly. Now, the one nice thing is that our guide is very, very visual and open. So when you are in this situation, edentulous, it's usually off a little bit, right? You can't help it, it's soft tissue. You can see what you're doing and you can make minor corrections on the fly, but that's not what we want. We want this to be perfect. And you'll hear me say a few times tonight, you want to leave a mount behind. And so what Dr. Castedo, and we've been preaching for a long time, is put an implant in that's easy in the anterior, 1, 2, 3 of them maybe. Secure the guide. Now your trajectory facially and your trajectory occlusally trajectories are stabilizing the rest of the metal so that you can put in your posterior implants, your pterygoids, everything is now really dialed in. Now, again, the guide has to be installed perfectly for this all to work. All right, so this case went from there to here all in one morning and did a lovely job. So most of these cases I'll have pre, post, and I always have pans, but some of them I won't have nice big smiling pictures at the end. And this is really more about the function, the purpose of what we're doing here as opposed to glamour shots. I have some glamour shots too. So here, this is another Adam. We're going to tell his story, and that is a second gen guide, pin guide. All right, that's the pinning guide is what installs the fixation base, our bone reduction guide. So again, this patient is in removable. You perform a dual scan. The patient came in with nothing. So we went through the normal general dentistry process, bite block, digital setup, try-ins like this. Maybe you do a wash impression with specific material, right, for dual scan, Kettenbach, Silginate, or green or blue mousse. Make sure those dentures are fitting perfectly for this scan. All right. There we go. And we did, of course, did our analysis of cross sections and labial support and all that. And once we get the dual scan here, then we are planning the implants, planning the fixation pins. We are, as you can see here, in a situation where we have limited real estate again. And we just have to nail how this pin guide goes in for the osteotomy guide, the fixation base. We have to nail it. And what you'll see here is we had the doctor do a 360 scan of the dentures, right? So it did a dual scan with the markers, but also did a 360 scan of the denture. And then we turned it into the pinning guide. So now we're a little bit more intimate fit on the locators, right? And these are locator abutments. We can do it on locator housings or straight right to the locator abutments, but this is a little bit better, starting to look better. All right, so this is as we're evolving with this case, because again, preferentially, we like to have the labial flap laid so you can pin the guide, the floating guide, and not have to come back and take the pins out and then lay a flap and then reinstall our bone reduction guide fixation base. We don't want to do it. We want to do this one time and move on. So in this case, because the pin guide fits better, lay the flap, put the pin guide in, hold it firmly, hold it very firmly. And I know maybe there's some minds out there thinking that maybe we could have the actual housings in the pin guide. It's possible, to pick them up, that kind of thing. But really, as long as the pin guide has a negative shape of those locators, we're going to be pretty darn close. Right? Nice installation. Implants are explanted. Patient had a lot of bone, so leave them out behind, put the implants in, go through the process. All right, so as long as this initial pin guide gets installed, the rest of it is going to be smooth sailing. I'm sure Savannah and team are going, yeah, sure. The only reason it's smooth sailing is because the doctor is so good at what he does. But he'll be the first one to put his hand up and say, I love this process. Even though he's so good at what he does, this makes it better. This enhances his approach to it because now he doesn't have to think all morning about aligning implants properly, about uh, placing them perfectly between the implants that are being extracted, the bone leveling. It's all pre-planned. It's all completely pre-planned. All right, let's transition a little bit over to fixed over fixed. Okay, but this one's going to have a little bit of a twist. It won't be the ultimate of what I'm going to show you tonight. But this was something that we dabbled with the end of last year, early this year, and that is using some scan bodies in order to digitize the position of the multi-unit abutments. Kind of a neat approach, but I'll get to that. So this is another case. This patient was actually on removable, but patient wanted to test drive the prosthesis. They wanted to see the bite, the smile, the tooth position, the feel of it. So this is a little bit more than most are going to do. But doctor put multi-unit abutments in, did a digital workflow in order to make prosthetics, just some kind of down and dirty prosthetics to get tooth position, smile, lip support, basically get the patient to sign off on this big expensive case with a test drive. Right. And so at this point, there's a couple different ways to go for records. The patient's stable, got a good bite, and this was early on. And so what we did was we decided that doctor would just scan the upper lower because they've been equilibrated. So scan upper lower, include some palatal tissue, which is, I will get to that a little bit, but that's really important. Get some palatal tissue. He put some scan bodies on the multi-unit abutments and digitized the patient. It's pretty creative. And then, and the next part will be kind of first time I've ever seen it. Dual scan here on the right. And what we did was we planned GuidedSMILE, kind of fun pictures here through the Real Guide software, again, of the limited real estate. And you can see why we want to have structure here when we do these cases. But we made pin guides that are made to fit the actual scan bodies. And this one really got us thinking, what the possibilities are, because it's kind of silly to put scan bodies in the mouth and put a prosthesis on it or a pin guide. But that's what we did. And doctor went through the whole process, pinned them, very stable. Obviously, there's flare there, so we had to block it out. He even had access from the top to screw him in while he was in the mouth because of the trajectories was a little tricky for draw. But that pin guide nailed the fixation bays perfectly, put it exactly where it's supposed to be. And we knew at that point that was going to be the way there was something here, right? Something here that would give us the precision. All right, leave them out behind. Conventional pickup. Most of these cases, maybe the first 60 or 70 cases, were full stackable GuidedSMILE prosthetics delivered in surgery, delivered with the case. All right, looking good. Upper, same thing. Nice position. Again, the pin guide was resting on the scan bodies. Implants come out. Implants go in. Leave them out behind for stability. And then just kind of showing off the precision of the whole thing. All right, so there you go, and then finish up the case. So a patient went from removable to fixed to ultimately to a long-term temp there. And you can see the engineering of that plan, the implants, the pterygoids. Now he was placing pterygoids guided. You saw that here in the, you can see on the back right, top back right. fully guided case to get these pterygoids in the right place. Really nice case. All right. A little recap, just a few seconds on this. This was a recap. So I'm kind of moving from left to right, where we did traditional dual scan, and then we started scanning the prosthetics. Then we started scanning the tissue and the locator abutments in the mouth, and we would use that scan of the mouth, and we would basically invert it and attach it to the denture dual scan for precision. And we just kept dialing it in, dialing it in. And then recently, I invented these arch bridges for locators. You can see it in the bottom right. You just click those onto your locators, and your locator position is perfectly digitized. So we're not totally rolling that out yet, but you can imagine the precision with a new style Grammetry scan body on locators, and what that will mean. So let's go through Jay. Hers is a little bit of a combination of what we've been talking about. Upper is fixed, lower is natural teeth. She has been in a she's been in a fixed hybrid for many years. This is just acrylic, repaired, super glued. A lot of love went into this case, holding it all together until it was really just time to restore. All right, so the upper is going to be a revision, the lower is just going to be a full arch case. So just real quickly with the records on this were obviously the photos. Use our checklist for the photos. Very important to pick the exact right ones because we use the photos for a lot of things. Bite, smile line, transition zones, vertical, smile, like all kinds of things. So we like to have the photographs. These are not the photographs. These are some of them. Intraoral scans, upper, lower bite. And again, I don't show it here, but make sure you scan the palate on these cases. Otherwise, you don't have any references. You got to scan the palate. And then on the bottom right, you'll see a 360 scan of the prosthesis. Okay. And then scan the prosthesis in the mouth because it's all acrylic. Doesn't have a bunch of metal. Alrighty. And then we work up the case. Right? Plan everything, plan the bone reduction, the pins, the implants, everything. And Jay's case was one of the very early ones that we did. So I'm moving them around a little bit here, but mostly for educational purposes because as you'll see on that image on the right, look how far labial our fixation base is. Very far. And that puts a lot of stress on the pins. This case is a pterygoid guided case. We don't want flex. We don't want movement or wobble, not flex, but wobble in the fixation base. But we don't have any choice because the patient's already wearing a prosthesis. And you can see the draw on the left image, how far labial we have to get beyond the teeth. Now, I know that there are guides out there that you put on the bone and then you come in with a fixating device, but there's just too much undercut for that. You have to have a bone reduction guide that's not engaging the actual bone, but is pin supported, and it's just too far labial. So this was one of the reasons that forced us into thinking another way to make pin guides. Very important, right? That whole, obviously, the pinning process. Now, doctor got through it. Did get some stability. Obviously, it's being inserted on the patient's existing teeth. So there's lots of stability there. But the real issue is, are you going to maintain stability through the whole surgery with 4 pins like that in the anterior? And that is why you leave them out behind, right? Get the first implants in, leave them out, secure it, and then you can address the pterygoids. All right, better situation. Now, this was early on where we first started doing some in-office printing. So just kind of worked it up just to get the case, get Jay out the door, home recovering, and then, come back later and do some pink. So a few weeks later, number 10 was lost and we wanted to replace it. We don't want to leave that long span with only number 11 there supporting it, right? So now we're at revision number 2 for the same patient in, a short amount of time. But we know what to do here now, right? Because we've been doing this. This is fast forwarding from her first surgery, but we know what to do. And that is take a CT scan. That is, patient actually went back in a denture temporarily. So scan the denture 360, perform a dual scan, and you'll think, oh boy, these are a lot of records, right? But do the dual scan, in this case, scan the abutments with the intraoral scanner. Now we can easily stack everything together, right? Palate tissue. And then, isn't that beautiful? On the right-hand side, micron mapper. So I had a Grammetry and now a photogrammetry protocol. So in the time we've been working together, Doctor bought a micron mapper. Scan those multi-unit abutments. Now we are dialed in. We stack the study model, plan the implant, right? And something else to consider, and this is something I should have mentioned earlier, is that the patients that you're seeing, all these patients, they are dental savvy. They have been through it for years and years. They have a high dental intellect and they're in a bad situation, right? So one of the reasons Dr. Castedo is doing so many of these cases successfully, getting patients to say yes, is because these patients are on the fence about what to do. More money, more surgery, more risk. And his whole stance to them is it's going to be guided. We're going to engineer it. I'm going to put that number 10 in there exactly as you see it on that screen. That's where it's going. Not going anywhere else. And I'm going to show you where the bone is, and I'm going to make sure that you have confidence that I'm going to deliver this case as I promised. How nice is that for a high dental intellect patient? They love hearing it. They say yes because of the precision of this. Now look at what we did here. Yes, over-engineered, right? But how much work was it really? There's no sleeves, right? It was just a micron mapper scan and some other normal guided surgery scans. We used the best screw in the world, in case Dr. D is listening. Great screw, vortex screw, cinches down, tightens it up. We can use any screw, don't get me wrong. Des, Rosen, Seg screw, any of them. We can use any of them. Screw it in, wait a couple minutes, screw in a little bit more, some tissue pressure, and then once it's down, you are going to be drilling in the right place. And again, these are all Nobel BioCare implants. This is their whole Nobel system, the voucher system. And so their guided kit is going to intimately put that implant in the right place. All right. Expose it, screw it down. You don't need all the screws. Put the implant in. Nailed it. Right. And then on the day of surgery, if you want, you already have a micron mapper. You can put them all in or some of them in and just pick up number 10. It's the same with any photogrammetry system. Pick up the one missing implant, make another prosthesis, and then go to a long-term temp. How beautiful is that? We went from revision 1, revision 2, and now patient Jay is happy for the first time in many years and went through it confidently. And let me tell you, Jay has a very high dental intellect. I don't want to give you any details of why. Very, very high. And that is why she was able to deal with this patched up prosthesis for so long, because she knows. She knows what she's in store for, and she wanted the vision of the doctor to get her all the way through the end. All right, so from black hearts to pink hearts, Jay did it. Nice job. Nice job. So screw down is was the way to go, and screw down is the way to go for a lot of these cases. All right. And what I'm going to do here is I'm going to go through Tim. I'm going to go through him a little bit quicker now because still have quite a bit to cover, and there's so many goodies in here for these cases that walk in your door. Okay, this is a tough one, and I have a tough time sharing this one because this gentleman, he's a veteran and little PTSD, grinding, bruxing, wearing his teeth out. To coin some terms I've seen, this was his second dentition. His first were the teeth he was born with and grew up with, and then he has his second. Then he has his third, and when he got to this point, he's just done. Doesn't want to do anymore. So, not really a revision, but I'm telling you his story. So, in the interest of saving bone, which is we promoted as much as possible, FP1 whenever possible. We went through an FP1 surgery. Dr. Castedo did a beautiful job. He even used these vertical suturing techniques. In the bottom right, pull the tissue, allow it to grow into place, allow the bone to backfill from the grafting. Just beautiful. Okay, so here we are at the fourth dentition, which is an FP1. We preserved the bone. We have nice crown and bridge, nice symmetry. Everything's going good. Patient's having a good time. And this is an interesting thing here. I won't dwell on this too much, but there's something you learn when you're doing FP1s. You give the tissue room to grow. We made a mistake here, and we designed it with tissue pressure, and we had a nice foam call on it. We opened up the embrasures on the right. See how we opened them way up beyond what you might think? And the tissue grew in. You'll see. Totally grew in just a couple of weeks. It's wonderful. Okay, so there's magic. I mean, it was like magic. 2 weeks later, the tissue grew in. But in that time, he lost an implant. Number 14, number 15, lost the implant. And now, where are we? We have a bruxing patient, a lot of parafunction. What are we going to do? We're going to over-engineer this case. Okay, so now we're at a revision. Micron mapper, intraoral scan of micron mapper scan bodies. I didn't mention that before, but that middle image, the pink one, that is, yes, that's a micron mapper export, but the bottom image, you just simply take your intraoral scanner, scan the tissue, scan the palate, and scan the actual micron mapper scan bodies. You don't need healing collars, not with us. Just scan them, and we can match that all together. Upper, lower, left there, upper, lower bite. Scan the tissue, right? Scan the tissue. It's ideal if you take the prosthetics out, scan the tissue. I'm sorry, scan the prosthetics 360. It helps a lot with aligning things. And then take a CT scan with the micron mapper scan bodies in the mouth. I don't have a very good CT of that, but take the CT with the micron mapper scan bodies in there. They're peak. Maybe they're partly metal, but it's a lot easier to stack when we have those in there as opposed to nothing or a zirconia or metal prosthesis with lots of scatter. All right, then the revision. Here we are. We have his prosthesis. We have, for alignment, for planning, we are going to add a couple of pterygoids. We're going to replace that that implant that failed. Okay, and this is what we're seeing on the screen. We're planning, we're making the guide. We know where the other implants are. Again, we have limited real estate, but here's the other key thing that we're going to talk about, and that is why we want to make a guide with that prosthesis out of the mouth. There's the guide, vortex screw retained, could not be more solid in the mouth. All right, let's go through the surgery. Simple stuff. Screw it down, put it in, and there you go. What a beautiful case. Beautiful. Over-engineered for a parafunctional patient. Tissue grew in. He's just in great shape. Very happy. Couldn't be happier. All right, and this screw down was our answer to the surgical guide that was left far labial to the prosthetics, right? Because of the draw, because the path of insertion in the draw. and the position of the teeth. So instead, eliminate that obstacle and just screw it down to the screw it right down to the MUAs. Okay, fixed to fixed. This is a screw down style, right? So now we've come full, not circle, with straight line. As we go through all these cases, we've been learning what is the best way to put these prosthetics, put these pin guides in to dial in the accuracy. So this is Jim, revision, upper lower, right? Upper lower, fixed. Okay, and he's going to go to more upper lower fixed. He needs prosthetic space. He needs more implants. He's got some bone loss, but he just doesn't have enough prosthetic space, right? And these prosthetics are getting old. Okay, everything's deteriorating. So what are we doing now? Now that we have learned all this, we are going to upper lower micron mapper scan, tissue scan of micron mapper scan bodies. And again, I'm not showing the micron mapper scan bodies in these iOS scans. Just scan them, the actual scan bodies, right? And then scan the prosthetics upper lower bite. Take the prosthetics out and scan them 360. We want that for stacking, for visualization, confirming tissue position, all that. Okay. Send us some nice photographs. He's been in a removable prosthesis for a long time. We got to check the overjet. We got to check the lip support. All right. So we're going to go through a full planning session with Jim, and we're going to make sure that what we're planning for is good. Now the upper, he already has some implants. And so what we decided was we're only going to add pterygoids and one implant in the back, and we're going to use the existing implants. He was happy to hear about that. And then the lower is just a full redo. We need the space, and those implants, we needed more AP spread, and we needed some more implant. If you get my meaning, we needed more implant. All right. Now, this is something to watch out for. See, this is another reason that we remove these prosthetics, is because we don't have the trajectory, the position, the room to get the tools in, right? The handpiece is going to hit the teeth in the posterior on the left images. And on the right image, we're trying to get an implant underneath the prosthesis. It has to come out. But you don't want a tissue-supported guide. Not for pterygoids, not for a dental savvy patient, and not for going between implants. We want to screw it down. All right. And again, that upper, it's not expensive at all. It's a simple surgical guide. We only planned 3 implants. We just did a little bit of extra work to allow the vortex screws to go in, but not that expensive for the upper. More like traditional surgical guides, right? And you need the precision, you need the balance, right? You need the balance of engagement, left, right, screws, torque it down, hand tighten it down, and then go to surgery. All right. So again, nice engineering. He walked in with this and walked out with that. And he's solid after a long time with old prosthetics that really needed some love. I mean, how much better is that now? Much more solid. All right. Kind of went through this. It's the same thing as the other case. So you have to, the reason we take these out is for making space. All right. So just a little wrap up on what the records are and what we did. So we went from left to right, traditional scan bodies, a few different kinds, whatever's in the drawer because it was working. But then we said, you know what? Let's do photogrammetry because you have the micron mapper. And then we also can do Grammetry. Those are the arch bridge scan bodies, but we can work with just about any of them. There's about 15 of them on the market, and they will all work for this. We're not looking for metal to metal final restorations or coney to metal. We're looking for really, really close, and the Grammetry scan bodies will do that for us. Right? And then just lastly, so we can do some questions. Uh, I hope I I hope that everybody sees that there is a nice avenue to revision cases, because if you're in full arch, they're going to walk in the door, and you want to be able to just plug them right into a protocol. So we have these checklists. You can, at the end, I have my contact info. Just send me a message. I'm happy to send them to you. And this will just walk you through it. Fixed, removable, whether the removable prosthetic has metal or no metal. That's different. That bottom left one there is for metal-based overdentures. You can't take a CT with them. There's just too much scatter. And then grammetry, photogrammetry type cases, depending on what you're presented with. Metal-based restorations or zirconia. All right. And then we could spend a bunch of time on record still, just dialing in the little details, but we can have a phone call about that anytime. Happy to take calls. I even stuck my cell phone in there. If you want to call me, you can always text me a picture of something you got going on. We love it. I love it. I love talking about it all day. And we pretty much have a solution for you.